Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of the Maternal Health Series, which is a collaboration with United Vessels of Love Foundation and Public Health in Real Life. The past two episodes, we've delved into issues with Black maternal health in the United States, maternal health disparities globally, and really understood some of the root causes of the maternal health crisis we see today. Today, in the spirit of Thanksgiving, we want to focus on highlighting solutions. And today we have a fantastic group of panelists who represent various organizations working in the women's and maternal health space. Our first panelist for today is Dr. Onikepe Owolabi. Onikepe Owolabi is one of the two directors of international research at the Guttmacher Institute. Prior to that, she was the Senior Director of Maternal Newborn Child Health and Family Planning at IntraHealth International USA. She was also a senior research scientist at the Guttmacher Institute between 2016 and 2021, during which time her research focused primarily on abortion and maternal morbidity measurement and measuring the quality of sexual and reproductive health care from multiple perspectives within the healthcare system. Dr. Wolabi has research and programmatic expertise in maternal reproductive health in countries in sub-Saharan Africa and Southeast Asia, and has authored or co-authored more than 40 peer-reviewed and other scientific publications. She completed her medical degree at Obafemi Awolowo University in Nigeria, her master's in global health at University of Oxford, and her PhD at the London School of Hygiene and Tropical Medicine. She was also part of the 2022 cohort of the Women Lift Health US Leadership Journey, which is an experiential and results driven fellowship for mid to senior career women in health whose work and partnerships serve target populations in low and middle income countries. You're welcome to today's episode, Dr. Wolabi.
Thank you for having me today, Imonat. It's lovely to be here.
Lovely to have you, Oni. Next on our panel, it's none other than the president and founder of Yuval Foundation, Miss Faith Adole. Faith is a visionary healthcare advocate, an experienced nurse practitioner and healthcare executive, and is currently pursuing her doctoral studies in executive nursing leadership and an MBA degree at the prestigious Johns Hopkins University. Speak of being busy. Ms. Faith is passionate about inspiring nurses and midwives to lead in global health settings and is committed to healthcare advocacy and bridging the gap for existing healthcare and wellness needs for the less privileged communities throughout the world. Ms. Faith has received numerous humanitarian awards for her global health volunteer service, including the Humanitarian of Africa African Health Heart Award and the Face of Humanitarian Award, amongst many others. Faith is a member of the American Organization of Nurse Leaders, Sigma Theta Tau International Honor Society of Nursing. You're welcome, Faith.
Thank you. Great to be here.
And our last panelist who would likely be joining via audio only is Dr. Marianne Etiebet. Dr. Etiebet has over 2 decades of experience in improving healthcare outcomes for vulnerable populations and transforming healthcare delivery at the front lines. Her various positions have included lead and executive director for Merck for Mothers and Merck's $500 million global health initiative, which helps to create a world where no woman has to die given life. Since 2011, Merck for Mothers programs and partnerships have resulted in healthy pregnancies and safe deliveries for over 11 million women in 48 countries. Building on her experiences as a physician, researcher, implementer, funder, and advocate across the public, private, and global development sectors, Dr. Etiebet brings a diverse set of perspectives to this work. Under her leadership, Merck for Mothers is catalyzing partnerships that leverage private sector capabilities to strengthen health systems, deliver respectful, high-quality care for women, and improve maternal health outcomes. Dr. Etiebet holds several positions, including board positions, and she's a member of the Center for Global Development Board of Directors, the UCSF Institute's Global Health Sciences, Global Health Group Advisory Board, and the High-Level Commission on the Nairobi Summit on ICPD 25. She also serves as the private sector representative on the Partnerships for Maternal, Newborn, and Child Health Board and the Investors Group of the World Bank Global Financing Facility. You're welcome to today's episode, Dr. Etiebet. They say a picture is worth more than 1,000 words, but a video even more. Please stay tuned as we just highlight some of the work that our panelists are doing with their various organizations before we delve into the live audience questions, as well as other questions.
I walked across, and then they light the back of my hand. I felt the earth beneath my feet, sat by the river, and it made me complete. Oh, simple thing, where have you gone? I'm getting old and I need something to rely on. So tell me when you're gonna let me in. I'm getting tired and I need somewhere to begin.
Reverend Father Abutu John Liu, the Hospital Administrator of St. Charles Hospital and Maternity, Adoka, Benue State, Nigeria. We are often confronted with a lot of challenges. Few among many include the issue of water supply, a standard ultrasound scanning machine, and even the postnatal ward, the prenatal, that's the women and the children wards, they require some attentions, like the roofs and the floors are bad, we're in need of mattresses and beds, as well as other equipment to help better the service delivery of the facility. And we believe strongly that the need for an increased health education for these women, as well as training for the healthcare providers, would aid in the betterment of the service delivery in the facility. And with our encounter with Yuvu Foundation, we have the faith that these needs would be met.
So now on to our questions. Dr. Wolabi, we talked about maternal and women's health issues, especially women's health issues more broadly. We know a lot of the priorities and the focus is on the maternal health issues. Could you shed some light on some of those broader women's health issues and how they in turn impact health outcomes overall?
Thanks, Maimunat. I think this is a really great question, and I'd like to start by saying that there's no unified definition of women's health, and traditionally, women's health has sort of been conflated with women's reproductive health. And I think that this historical fact is really important because for everything we'll talk about today, it sort of is the root of what it means to be a good woman. And you will often find that even in 2023, when we dig deep under, women have been primarily valued for their ability to reproduce and to bring forth children. And so this reflects in the areas of their health that are prioritized in the budgets that are allocated to certain parts of women's health. But sort of stepping away from how our patriarchal world has often limited our health to our reproductive anatomy, a lot of people, there's some really good framings where you can broadly think of women's health as the female sex, so not gender, but sex, affecting general health conditions. And this means that under that umbrella, you can think of conditions that affect women differently from men, and this will typically include cardiovascular disease. And so for those of us who know heart attacks and strokes and hypertension can show up very differently in the female population than in the male population. You can also think about diseases that have a much higher prevalence in women than in the male population. And this is often the autoimmune diseases. You're more likely to see migraines, osteoporosis in women than in men. And then, of course, you can also think of conditions that often come about as a result of gender bias in health delivery. And that has a lot to do with pain, women's perception of pain, dysmenorrhea, how surgical pain is managed in healthcare service delivery. And I think very broadly that there's that group of conditions. And then there are the group of conditions which we of course recognize and know that are very specific to females. So like contraceptive use, and we already know that the burden of contraception often lies on women. Maternal health conditions, so things having to do with pregnancy and childbirth, which of all women's health is probably the area where funding is greatest. But then minus those, there are other understudied and under prioritized reproductive conditions. So when you look within gynecology, endometriosis, pelvic floor health, menstruation, menarche, and the sexual health of women are areas that we don't talk about broadly and we don't allocate a lot of funding and resources to. And then the broad group of female cancers, breast, ovarian, cervical, which are gaining some traction in today's global development space. And then, of course, gynecological infections, vaginosis, HPV, STIs, which have sort of waxed and waned as HIV and associated conditions have been popular and non-popular. And I think I'm very grateful for this question, because women come as whole people. They aren't just reproductive autonomy. All of a woman's life is important, and her health is influenced by the social conditions, by the financial conditions, by the environment she lives in. And all of this has an impact on every aspect of her health from birth until death, far beyond her reproductive years.
That's you've really shed the light on a lot of issues related to women as individuals, not just as birthing or reproductive people. Faith, I would the next question is really focused on you. So I know Yuval has done a lot of work addressing those issues that Dr. Oni has highlighted. So what are some of the gaps that Yuval is currently working on, and what is still there left to do? We can't hear you.
Sorry, thank you. Thank you so much for the question. So Yuval Foundation is an international healthcare relief organization. We're mainly focused on primary healthcare services. That encompasses a lot. It also encompasses women's health that Dr. Oglabi touched on. So a lot of the gaps that we see are, number one, I'd like to highlight, are preventable. So we tend to see mainly in rural or remote areas, huge gaps with healthcare access, everything from infrastructural issues like bad roads, physical things like that, or a facility might be lacking basic things like water, equipment, those types of things. Then we also address things like workforce capacity. We find that a lot of the communities that we interface with and collaborate with, they will have a limited number of healthcare providers, and they will be mainly unskilled, or they might have one skilled for a large region that encompasses several, maybe counties or villages and those types of things. And then health education is a huge gap that we see too, both for the providers and for the community. And it goes back to just lack of access. So we do interface a lot with a lot of cultural stigma or practices that people are just practicing just because they've done it, they've seen others do it in their community, but aren't necessarily good for them. So these are kind of the gamut of things that we see on the field and try to address.
And what are some of the success stories you have encountered so far?
Sure, there are several. Since in light of this talk, since we're focused on women, I do like to highlight, even though our services are very comprehensive and we see everyone throughout the lifespan, men, women, and children, about 85% of the healthcare recipients that are in the communities that we serve that come for our services are actually women and their children. So that's something that's unique that I love how Dr. Owolabi talked about we can't just focus on the reproductive system. There are so many things that we see. So a lot of the times, even though we're focused on primary health care, just to give you an idea, when we're out in the field, sometimes the folks that we see haven't received health care in so long. And they show up, it might turn into an emergency room or an ER. So we've actually saved lives on the field. Women may come with very high blood pressure that's very dangerously high, that, well, if we were here maybe in the States, that person would be like in an ICU or admitted or something like that. So we have those instances where we intervene there and help to deter things like maybe imminent death or something that could have a really bad health outcome. Also, we have stories where there are kind of everyday things that I wouldn't say every day, but here, maybe in the United States, something like wound care seems to be something that can be easily accessed. Someone over there might have a wound for a very long time that started out as small and then continued to get bigger and lead to more issues. And so we've treated quite a bit of people with some sort of like everyday sort of things that we see in a primary care practice, preventing it from getting out of hand by just providing one education, also some tools, resources, supplies to that person so that they can go about their everyday lives, whether it's work or school. So we see a huge gamut. Yeah, thanks.
Yeah, yeah. So, Dr. Wolabi, piggybacking off of what Faith just said about what they've done with UVOL Foundation, I know you've done a lot of work in research, implementation, policy, and all of that in sub-Saharan Africa and Southeast Asia. So, what are some of the challenges you've worked to address, and what were the innovative ways you overcame those challenges?
Thanks for the question, Maymunat. So I'm sitting here wearing two hats. So one, as the director of international research at the Grimaka Institute, where we work a lot on sexual reproductive health, and also as the research and strategy lead for Maternal Reproductive Health Research Collective, which was in the video that Maymunat showed earlier, and that's in a nonprofit in Nigeria that I have been working with our founder, Dr. Folabi, on for most of my career. And I would say that in my day job, I do a lot of population level research, and with MRHR, I do a lot of implementation style research and programming. I think that many of the issues I've worked on very strangely, like Faith said, are very simple things. Oh, it's how to collect data and how to measure things, and it feels a bit disgraceful to say it in 2023, but in many of the countries I've worked, we do not measure things enough. We do not measure them properly, or we don't have any data at all on some things. And so, for some, when we think of sexual reproductive health broad rate, I think that we have, at the global level, improved a lot in how we collect some indicators of maternal health, so antenatal care, family planning. But for some of the work I've done, things like unsafe abortion, gender-based violence, the prevalence of reproductive cancers, those are things that are very hard to measure on account of the stigma associated with them. They're not routinely documented within our health system. So however the health system collects data, whether it's DHIS2, which is the routine health information system, or in private hospital data, those are not conditions that we document systematically, and the failure to document them thus means that the government doesn't understand how big of a problem that is, and we can't allocate funds to the health system to manage them. So a lot of my work focuses on trying to measure those and sort of fielding surveys and creating questions that allow women to report on things that are very challenging for them to in those contexts. In my work with MRHRC, some things that we're trying to do, which there's an increasing need, there are better ways to do them this year, are things like documenting quality of care. because in everyone's mind we're like, oh, we want high quality of care, like Faith was saying, we expect, oh, you go to a facility, and how do you measure quality? That's a question I ask myself often, because you think of, do they have equipment, do we have processes? But then even more important, what is a woman's experience of care? And even for those of us who live in high income countries, if you think about it, that's not a standard question when you go to the health facility. No one asks you, were you happy with your provider today? Were they respectful of you? You might get it once in a while. And so that's something that I'm doing a lot in my work in Nigeria currently, is trying to work with primary healthcare centers in Lagos State to collect information from women on their experience of care at the facility, but beyond that, what they would like their experience of care to be. What are the gaps that they see within the health system, both big gaps like infrastructure or water or cleanliness, but also other gaps like cultural competence. How are health providers talking to you? Why do you have a reluctance to use free public healthcare facilities and use private healthcare facilities that might not necessarily be of such high quality? And we're using some new innovative tools to do that. We're working a lot in communities to do things like town halls and focus group discussions and big meetings to sort of capture it at a community level. And then I think I will probably get a chance to talk about this a little bit in the future, where sort of in Lagos launching a program where we're trying to set up a community-based registry where we have health workers go to women's homes routinely and collect this data from them, because it's very hard to rely just on health system data. So we're trying to set up a community-based monitoring and surveillance system where we are tracking women throughout their reproductive lives and collecting information about what they got, but their experience, how they felt about the care they received at their homes throughout their pregnancies, and the impact of this care on their subsequent outcomes.
Yeah. And in the spirit of key performance indicators, just like you talked about data and measuring, Peter Drucker is often quoted for saying, "You can't manage what you don't measure." So that it's great that you're highlighting that aspect. No, so coming closer to campaigns, then, Faith, can you tell us about the UVOL campaign that I know was just recently launched? How is it working to improve women's maternal health, and what are some of like the bright spots or success stories to date?
Sure, thank you so much. Yeah, so Yuval Foundation just launched a campaign called the Value Her campaign. So the campaign itself is kind of a prelude to our pilot Value Her program that will actually be launched next year. So right now we're focused on raising awareness about women's health, the whole gamut of women's health, and maternal child health as well. Essentially, though, I'll talk a little bit about, I guess, why it exists and then what we hope and aim to do next year. So, essentially, the areas that we have been working in primarily throughout the north central areas of Nigeria, the maternal morbidity and mortality rates, also newborn mortality rates, are extremely high, and they couldn't be ignored anymore. I mentioned earlier that primarily like 85% of our, whether it's medical outreach or we're impacting a community with clean water, most of those inhabitants or who shows up to receive care are women. So our initiative aims to help educate, enrich, equip, and empower women and girls, also the healthcare providers that care for them, through increasing access to health education, training, skill development, and peer support. And more specifically, in our pilot program early next year, this initiative will help to about 1,000 to 2,000 women, kind of across the lifespan, an estimated 500 newborns in underserved areas in the north central of Nigeria. Some of the work that will be included with this initiative, what we're focusing on is, of course, providing increased access to high quality women's education, antenatal care, wellness services. And another large part of it is empowerment of the healthcare providers. So providing them with skill development and training, specifically midwives, nurses, community health workers, and all of that. And some resource support with things like basic equipment that doesn't exist in these areas, like ultrasounds, how to use them, providing midwives with kits so that we can have safe deliveries, or providing education to prevent things like postpartum hemorrhage and just other deaths associated with maternal health. So that's essentially what the Value Her program is about.
And we're looking forward to all the success stories and lessons learned from that for others in this space. So, Oni, you, in your research experience and with the expertise you have, you've worked with, MRHC in a low-income setting. You do work in Guttmacher Institute, even though its influences work in LMICs. You are primarily based in a high-income setting. So, how is research capacity built, and what are like the differences in research capacity in both of these contexts from your perspective?
That's a good question. That's a political question. I'm going to. I think the first thing I want to say is that capacity is a strange word. I feel like it often conveys an inherent ability to do something, and with everything I say, I would like to remind us that the funding available for health services, the funding available for science, the quality of educational institutions, all of these are sort of rooted in the history of the countries where I love and work, and so inequitable access to certain kinds of training is tied up in our colonial past, and so capacity has nothing to do with the country's inherent ability or people's capacity, people's mental aptitude, but has a lot more to do with access to resources. So that being said, you will find that everywhere you go, there are astounding researchers. I say this because research is most valuable when it is grounded in the context, when it is people who understand the systems they are dealing with, when the questions are pertinent to the problems we want to solve, and when people are able to understand the complexity of the places where the research is being collected. All of that said, as a researcher who has had the privilege of being trained in high income countries, there are certain tools and languages and skills that you will often see overrepresented either in high income countries or by people who are trained in high income countries. I feel like as a Nigerian, Nigeria is particularly fortunate because we have a large number of our population who are highly skilled scientists, both clinical and researchers, and have often been trained at some of the best institutions in the world, best, quote, quote, best. And so we do have a large pool of researchers. But Nigeria, like many West African and other African countries, on account of the availability of labs and institutions and funding that is allocated to science, doesn't often retain most of its skilled talent, and people are not able to work in country. This means that, and something Faith has said that I think is important to bring into this thread, is very often from a high level as researchers, we see problems and we're like, oh, this is important and I want to solve this using my lens. But when you go in country, it's complex and there are multiple issues. So you want to solve a maternal health problem, but there's problems with water and sanitation and with roads and with infrastructure. And then the question becomes, what are the actual important questions to answer? And how do you frame these questions within the broader context people are living in, to not just derive an academic answer that is suitable for you, but to understand that these health systems are embedded in broader social contexts, and you really want to answer those questions properly. And so in my work in Nigeria, I am very lucky to work with talented people, but then I often find that for quantitative methods, for having the capacity and the time to formulate a question and not just focus on delivering programs, because the situation can be so dire and acute that you want to do things and not ask questions about what you're doing, there is a space for paying people and bringing in some of the training I have and teaching them how to do research, even as they do the all too important work of delivering programs and pushing the community forward. Um, I find that in the context I work, because of the internet, because of slow internet, because of sometimes access to financing, it's much harder to gain very high level quantitative design skills. So if you want to run something like a randomized control trial, you want to do econometric analysis, you want to do costing analysis, those are not things that are universities in Nigeria are graduating a large pool of people to be able to do, or even if they're teaching it theoretically, they don't necessarily have the exposure to enough field projects to be able to do it a number of times and gain up-to-date skills. And so in a lot of my work, both at my full-time job and with NGI support, I work with a large pool of Nigerian researchers who are really investing in transferring knowledge to people. At MRHRC, on account of the generous funding from some of our donors, we have physicians and other scientists who are able to undertake doctorates and master's degree and then incorporate that training into the work they're doing, which I think is extremely relevant and extremely valuable because they already understand the context. And once you give them those tools, they can go forth and really ask questions and really improve the quality of the work I would do as someone who lives in a high income country. And yeah, so to answer your question broadly, I find like the aptitude and capacity to be pretty much the same everywhere, but access to the tools to be different between both contexts. And I am very glad for the opportunity to be able to work with excellent colleagues in my home country to facilitate some skills transfer, not all from me, but from colleagues who can. And I think that it is important as we fund programs, as we do humanitarian outreaches, to always create that space for people to ask questions of the work they are doing in their context, to be able to iterate and reinvent and look at those questions from a health system value, because incorporating that evidence into how we're developing and designing programs allows us to push our health system forward faster. Yeah.
Yeah, that's a really insightful discuss. On that, in a similar vein, Faith, the Reverend talked about health workforce development in addition to everything else. You are a nurse practitioner here in the US, and I know you've also done work in Adoka in Nigeria. So, what are some of the similarities, the differences, the lessons learned, and how do you think those would shape how we build the workforce to be responsive to the healthcare needs?
Sure. Thanks for that question. If I may first, I'd love to just, if I can add a little bit to what Dr. Olabi said, just a bit about research, because I think it's really an important thing to highlight, especially as a healthcare service organization that UVAL is, that's healthcare relief. I think people tend to forget how important, how much we need healthcare research, how much it informs our work, why we should be collaborating with research organizations and such. So, of course, the care that we deliver provides data, information to do research, but the testing of research, the actual practice of research informs what we do. One of the reasons why UVAL has the model that we do with a high focus on quality and also sustainability and not like a typical necessary missions organization is because when I got into this work, and kind of ties into your question you just asked me now, I find that here in the United States, we've got tons of standards and a lot of evidence-based practice readily available at our fingertips to use when we go and practice in an area, existing research from a long time ago. However, in Nigeria or Uganda or South Africa, the places that I've worked in in other places, research has been somewhat limited compared to what we see here. And then when we talk about things like standards, it can be difficult because what standards do you use? Do I use the ones that are working in this setting because it doesn't apply here? It completely disregards maybe cultural aspects, norms that have been practiced in that area, etc. So one, I just wanted to highlight that it's super important, I think, to have more research in the continent of Africa. I think that's very important, especially led by clinicians that have worked hand in hand with patients in the field. I think that informs our work a lot. Here, I find that I'm now currently in school, and we're focused in my DNP in quality improvement programs as a nurse, but that are field-based. It's a DNP program separate from the PhD. However, when I work in Nigeria, we don't see that as much. So a lot of my passion and hope is to really try to inspire other nurses and midwives to participate, not just in service delivery, not just in leadership, but also in research. It's very much needed. And in comparison with high income countries, we still have a large way to go. And there can be a huge danger in relief work, or in that it can be viewed as patchwork. And in reality, it can be patchwork if we're not careful enough to recognize, I guess, the complexness of what we're doing and why we need evidence-based tools, why we need goals for every program, whether it's a short-term 2-week or it's a 6-month or a year. And we could be doing more harm than good in the name of, well, we're doing humanitarian service and work. But if we look at high income service countries, we don't, whether it's short term, whether you go in for a surgery that's a same day surgery and come out at a surgery center, that place has standards. Or if you're at a long-term facility, that someone's there after, a long illness, that place has standards that we need to follow. So those are the things I just wanted to highlight of the differences and where I hope we can go, and that I think research is super important.
Speaking of standards, evidence-based, and all, Dr. Wolabi Oni, how do you measure the impact and effectiveness of some of these initiatives and campaigns and ongoing solutions working to address maternal and women's health issues?
Yeah, thanks, Maimuna. That's a really good question. That's an excellent question, actually, because we have a lot of campaigns globally, and I'm very excited to hear about Faith One, and MRHRC is running one called Women for Her. But then I often smile because it's so hard to take something like a national level or even subnational campaign, and even the global ones, and then really isolate its impact on outcomes. And I tell people that very, very often, even though not everyone likes to do it, when we launch things like campaigns, I think the first thing we often need to ask ourselves is, what do we realistically hope to achieve? And whilst I don't think, it should become a Bible or a religious document, I really like the theory of change model, where you sit down and you ask yourself at the high level that if I do this big thing, what do I want to achieve? But then what are all the downstream outcomes at different levels? So what's the big outcome? What's the intermediate short-term outcome? What are the, like how many people will I reach at the output level? And then when I reach these, how many people, what do I think they will do? And why do I think they will do so? I feel like for global campaigns or for national level campaigns, sitting down and drawing out a framework for who your audience is and how that campaign will influence and change your behavior is a very important step that we often miss, because we often think this is a great idea, I'm going to mobilize youth, and then it's like, and so what? Like, what happens thereafter? I think that traditionally in my field, when we see large global campaigns or initiatives, when we want to document the impact, people often qualitatively summarize things. So I held an event, 10,000 people came and they went back to their chapters and did things. But I think that we're not very good yet at being willing to drill down into, having hosted this event in multiple spaces over multiple times, what did those people do with what they heard? And then how did it translate into individual level outcomes that actually moved something forward? So, for example, if you run a campaign for sexual reproductive health or maternal health where birth safer, did mortality reduce? And even if mortality didn't reduce, did indicators on the way to mortality reduce? I think one example I really like to highlight, because I love the show, but also because I really enjoyed seeing the work to measure it, is the MTV show Sugar. I don't know if you've seen it, but Sugar was the first time I saw Lupita Nyong'o. I really like that. And it was launched by MTV in Kenya, I believe. And it was focused, it was edutainment. And edutainment is its sort of campaign. And it was focused on providing high quality information in HIV prevention to young people. It was a very thoughtful show, and they ran it in Kenya, South Africa, Nigeria. There's MTV Sugar Nigeria and Cote d'Ivoire. One of the great things about Sugar is that as MTV hosted it, they funded a full impact evaluation, which academically means they funded a research institution, the London School where I was at that time, and colleagues, to deliver the show in a very almost experimental way. So show it to a group of people and not show it to a group of people. And over time, so 6 months, 3 months, a year, and even further, try to see what impact the show had on information and knowledge uptake by young people, on the use of barrier methods of contraception, and then in the much longer term, on sexual activity and outcomes. I know that we realistically cannot do this academic style impact evaluation for all campaigns, but I think that it is inherently valuable to conduct studies like this because it tells you realistically how much you can expect out of this. And then, like Faith was saying, it highlights where the funnel trickle down effect ends and what you need to pick up to actually get to the end you achieve. For Sugar, it was a very successful show, which is why it was scaled up to other countries, because it showed a huge increase in awareness of HIV and sexual behavior, and for the subsequent shows, gender-based violence, IPV, intimate partner violence amongst young people, because it communicated with them in a very compelling way. If you ever watch the show, they do very, very cool research things. They poll people during the show. So you often say, what would you do question before the next scene. Now, it showed that information increased. For some countries, it showed that practices changed. But one thing that some countries show is that at the population level, it did not appear to have a long-term impact on things like HIV prevalence. That's very useful, because if information increases and people's behavior change, some people's behavior change, what it's sort of telling you is that with that kind of campaign, you probably need some more grounded community work to pick up on the changing social milieu and ground whatever youth community that is to eventually see changes in HIV prevalence. And sometimes people are reluctant to do research on big global campaigns and measure it because you're like, oh, maybe it won't be successful. But I'm like, it will tell you how successful it was, and it will highlight where you need to put in place other health system interventions, community-based interventions to pick up on the level of success and translate it into the bigger health outcome we want. And so I think that, as someone who really enjoys SRH and the young people space, that Sugar is always a really good example of how we should run large health campaigns and support, like Faith said, the research behind it to measure what we're really doing. And you will often find that if you want to do research on whatever campaign or initiative or effort you are funding, there's a tendency to be more thoughtful in the design because you don't want to have no results. The flip side is, of course, no one wants to share unsuccessful results, but approaching all initiatives as a research question and saying, what is the pathway to the outcome I desire, inherently improves the design of what you're delivering. And then if you have the capacity to measure it, helps you identify gaps and go back to the drawing board.
That's a very interesting perspective in the business world in terms of failing forward, and then giving room to fail, because failure is where you actually learn. I think in global health, specifically health, is there's this whole notion of scarcity, and they're not investing in M&E at the project design phase, and not sharing results of failures, because then how do you publish in peer reviewed journals? And so it's really a whole gamut of factors that play into taking that lens of it's not failure, it's actually lessons learned. Speaking of technology and, like you said, edutainment and all the different ways you've all has worked or found solutions, and this is a two-part question, and I would ask you both, how do we leverage technology, or how do you work with stakeholders to leverage technology, including even artificial intelligence in this day and age we are, to improve women's and maternal health issues? And the second part to that question is, how do we limit further disparities? So Faith, you go first.
Sure, thank you. Yes, I think that's a really great question. I think that every healthcare organization actually should be thinking about how to address that question, just because of the current climate that we find ourselves in. First, I'd like to just say that in the kind of work that we do, there are a lot of pressing, I would say, challenges that are kind of right in front of our face before we can really utilize technology the way that we would like to. So it would be hard for me to ignore those things or not mention them. But some of the issues that we have in first utilizing technology or implementing that in the work that we do is very much infrastructural. A lot of the places that we go to are very rural, very remote, don't have basic things like electricity, don't have water, and those sorts of things. So UVOL is very collaborative in that we are very much part advocacy, part service delivery. We do our best to highlight some of these issues that exist to our global partners, so that hopefully we can, move the gamut and change things in these areas. So then we can focus on maybe helping to improve digital literacy, things like that, introducing electronics in the work that we do. Then I'd love to say that in our work that we do, it could be one of the maybe incentives for our stakeholders, whether it's government, local or state or national, to really partner with what we're doing and trying to help make the gap smaller in some of these issues that we see with infrastructure and electricity and all, is that we can actually move the needle faster in increasing access if we address these things, so that we can adopt things like maybe telehealth. So if we have an issue with healthcare providers, we don't have enough of them, we don't have enough skilled ones or educated, maybe we can look at ways of educating them virtually, or a hybrid type of model, or increasing digital literacy in the community for healthcare providers, those sorts of things. And then other technology too that help aid service, healthcare service delivery, as I mentioned, ultrasounds and all of that. It's one thing to just introduce and bring all of these technologies there, but then, as we've mentioned earlier, there are a lot of realities on ground that actually prohibit us from using them or using them effectively. So even if you have good roads and good access, and you have enough healthcare providers in an area, if you drop any kind of device with them and just say, well, good luck, we solved your issue now, that would actually be very counterproductive, I think. So I think the answer really is it would be super helpful, I think, in helping to close this gap with access to healthcare and global health. But it takes multiple stakeholders. It takes addressing multiple things before we just say let's just embrace technology. That's my viewpoint from a health relief organization.
Oni?
I mean, I think faith has brought like the truly critical lens, which I always appreciate because I recognize that our world today we love technology. Like just for the sake of technology, we love it. And I think what you described is entirely accurate in that we it's a tool and there needs to be a lot of scaffolding in place to use it successfully, but then it is a very disruptive tool and one that I think I really appreciate. And I'll give like a few examples of what I think can be powerful use cases, and then I think we'll probably go we should keep going back and forth on how to use this, especially for women's health. So couple of years ago when I worked in Yobe State, it was very interesting how, like you said, there was not always regular electricity, and there was not running water in all the villages I worked in, and many people didn't have smartphones. But there were a lot of phones. Now, the ethics of who owns a phone, gender autonomy, gender equality, is it controlled by men, existed, but there were phones. And at that point, we were working to set up like a small cohort of women to monitor pregnancy and delivery. And even with those very cheap burner phones, I remember us giving our data collectors, who were all women from the community, we gave them money to charge them at the central charging point. So because there's no electricity, you get a generator and someone would charge your phone basically. And every time there was a delivery in their immediate community, so they would walk around or bike around and pick it up, they would just send you a standard text. And thinking of just how powerful like an SMS is to say baby was born, we weighed the baby, it was one or two mothers' outcomes, just dramatically gave us an insight into the health of the population that we could not get any other way. You know, women in that community were not routinely having babies at primary healthcare facilities. The records were poor. If they're paper records, before they get to you, everything would have happened to them. But a simple text message for the period of that research study transformed our capacity to understand what was going on. And that's why, even in its cheapest form, that technology changed what we could measure. Another example that I have seen recently is from my work in Rwanda. And Rwanda is a small country and one that is very innovative in how they are leveraging technology, where they're using drones to deliver blood. And so when a hospital needs that critically, you can basically get blood in 20 minutes. And being from Nigeria, where I understand the restrictions around access to blood and how hard it is to make it available, and even in urban areas where technically there are bigger blood banks, you have to deal with traffic. Just seeing a doctor send like a message and the drone drops like a unit of blood or 2 units of blood, and like you said, preserves life. It's so remarkable to see how that can work. And so I think the third case sort of alludes to what you said. So at MRHR, we and our founder, Dr. Fabi, they have a study ongoing with colleagues and friends at Mayo, where they have brought in the technology, iPads and some applications, and they're using it to conduct very detailed ultrasounds, and they're using AI to detect cardiomyopathies in Black women. And that's a cardiac condition that is very prevalent in Black women, and in northern Nigeria is thought to have one of the highest incidences. And it's very, very interesting and useful because the amount of training you would have to go through to become a cardiologist, to read that on your own, that level of hyper specialization, and the staff to the amount of staff you have who can go through that, and the funding to do that is not available. But then things like artificial intelligence, when they are carefully trained, of course, understanding all the challenges that come with AI, suddenly give a health worker a capacity to accurately diagnose a condition they're unlikely to have seen before, and allows you to provide care for a woman whose life is at risk. And in that third example, I think of how this really extends healthcare. Faith was talking about telemedicine, but in providing clinical support, decision-making tools for people in the furthest and marginalized places. But then with all of that comes the ethical responsibility of connecting that healthcare provider and that woman to someone who can then treat adequately. So I think that's the flip side of it. But I think that technology can be very powerful when it is designed thoughtfully by the developers in partnership both with the users as providers and the end users as people or women and health systems. When we adapt the applications, the tools, the artificial intelligence, the chatbots to be culturally responsive. So even as people think, oh, we can do more, I'm like, for many countries, you need to do more with less. So things that can be charged with solar power, things that are inexpensive and low cost, things that you don't need to replace a certain part every 3 months at $6,000. I feel like we need to be very careful in how we design those things. And then for me, leading the research arm of multiple organizations, really using that to be able to collect data and talk to people and pull data quickly and examine it quickly to understand how things are changing in the community is very powerful and very critical for my work.
Thank you both for sharing that insight. And speaking of technology, after many tries, we're finally able to get Dr. Etiebet live. So this is one of those use cases of the role of technology and making sure that we're not, furthering the disparities in access.
Yes.
So yeah, welcome to the live stream, Dr. Etiebet. We have
Thank
been
you.
chatting about, broader women's and maternal health issues. So I'll go straight to some of the questions that we have for you.
Thank you.
What are some of the global campaigns that you are aware of or that you have been part of in your work that are addressing maternal health issues, but also broader women's health issues?
Yeah. No, thank you so much. And I was just listening just before now to Dr. Wolabi talking about how we should be listening to women and how we think about making sure that their perspectives and recommendations are integrated into all that we're doing. And I think that the global campaigns that I'd like to highlight are doing exactly that. So whether it is the What Women Want campaign, which has been created a number of years ago now through the White Ribbon Alliance, and they've had multiple iterations of the campaign. And the most recent one was relying on technology to support, scale and acceleration of the results. I think one of the things that was both surprising and it shouldn't have been surprising, the number one demand from women was we want respect. We want respect and we want respectful care. And I think that just goes to serve to remind all of us that at the end of the day, if any of our work is not grounded in what is happening at that interface between the system and the birthing person, the woman, then all what we are doing is actually, I would say, deluding ourselves that we are doing, something right. I always like to say health systems, the last mile of the health system is not the primary care facility. The last mile of the health system is that interface and that reaction with the woman at the center. And what has been interesting is it has been to see how people, both in the technical space, in the donor space, academia, government, NGOs, etc., how they are responding, to that demand, how they interpret it, how they now reflect it in their work and what they're investing in and how they're thinking about researching the effectiveness of their work. And I would say that sometimes we actually, I would say, lack the courage and conviction to actually listen to women. Sometimes we take the easy way out to say, oh, it's too hard, to actually understand women's experiences. We don't have the right metrics to be able to measure respect. It changes, due to cultural differences and kind of cultural interpretations of cultural context. Oftentimes I think we make all of these excuses to do what we actually know we should be doing, because we are hearing this is what's going to make a difference for women. I'd like to also give another example, also through another of the campaigns that the White Ribbon Alliance implemented. And that was most recently, speaking about what's most important, for women's health, and over a lifetime, over a life course. And many women and girls said it was education, it was a living wage, it was economic opportunity, it was freedom from violence, it was being able to eat and provide for your families, it was safety. All of these things that we, I think in the jargon, call the social determinants of health. And what was actually very interesting to me is about 80% of the responses were in those social determinant of health categories. About 20% of the responses, spoke specifically to health needs. And, oftentimes, because I think I've been on panels with a number of you before, we talk about 80% of health outcomes are actually driven by the social determinants of health. So, these women told us we didn't have to have a randomized control trial to say 80% of what people believe will keep them healthy over a lifetime actually are outside of the health sector. And again, it will be interesting to see how all of us, the community, global health community, interpret those results, and how, again, we use them to inform resource allocation and decision making. And one of the things that I would say, thinking about campaigns, and which is why I do think it's very important to locate these campaigns, from the perspective of the end user, because they understand how everything works together or doesn't work together, come together to serve their comprehensive holistic needs. We on the health system side are still working in silos, and we still can't figure out how to think through how to pull together education and health, or social welfare, or even infrastructure, to think about working on all of these things, to support all of these myriad of demands. So I think, to go back to your question around global campaigns, we need to do more to have these campaigns be rooted in communities, rooted in people, and have the responses be multisectoral in order for us to actually see impact.
Yeah, it's funny as you were listing all the different aspects, the social determinants of health, the reminder on the 80. Previously, we talked about, Peter Drucker and KPIs. You can't manage what you don't measure. Two things stand out. The end user is the one who gets to experience healthcare. On the other end of it, governments or ministries of health, in this case, are responsible for population health. So in between is where all of us play out, the different stakeholders, the decision makers, the implementers, the foundations, the researchers. So what is the role of the different stakeholders in ensuring that there's this consolidation of efforts that prioritizes the end user's need, but then also eliminates waste in the space? Address that you, Dr. Etebet.
So thank you. I do think ultimately, we need to hold ourselves accountable to listening to the end user and hold ourselves accountable to responding to the end user. I don't think we do that enough. And as I said, I do think sometimes it's easy, for us, or it can seem easy for us to discount that, the end user is, quote unquote, not educated, or quote unquote, doesn't understand how the system works or how complicated it is. Again, I do think that sometimes these are excuses, for privileging certain types of knowledge over others. And so one of the things that we should do as a community is figure out ways to hold ourselves accountable to what end users are telling us. We should not be evaluating any programs without a real robust inclusion of end users across the life cycle of that evaluation, identifying, what good looks like, what would be the metrics of success. How do we best, in a non-burdensome, equitable way, collect the data? How do we make sure the data is shared? How do we make sure that it's interpreted, with end users? How do we make sure that it is the results are transparent? All of those things must be done in an inclusive, participatory way with end users. I often think sometimes if we focus on process, on how we do things, some of these things will I don't want to say will happen naturally, but the system will be incentivized to get to that end goal. But if, for example, we say we want to make sure that we have patient-centered or women-centered metrics in how we evaluate our programs, but we don't involve them in the determination around those metrics and how we do the work, we are just going to be perpetuating the inequities that created the situation in the first place. But I do think if we focus on process and how we do things and making sure that women, all women, diverse women, are integrated in how we do this work, then the results will come out without too much I would say too much debate.
Yes, we again, it's just been great hearing you all speak about these broader issues. And yes, it's it's an honor that we could eventually have you, Dr. Etebet. We have about 8 more minutes to wrap up, but I still want to ask some targeted questions. But before I do that, I think one question I have for Faith specifically, especially with Yuval Foundation, is can you tell us what has inspired the work with Yuval? And what are some of your 5 to 10 year goals and dreams?
Sure, thank you so much. So I think what inspires Yuval essentially, it's kind of what inspires me as a founder. Yuval stands for United Vessels of Love. So a lot of our focus is partnerships with others, uniting for a good cause, in love that it translates into service delivery, but really just showing that everybody matters. Everyone, no matter where you are, we have terms of high income country, low income, or rural, remote area, or a urban area. But everyone matters no matter where you are. Things like basic needs, whether it's water, education, healthcare, just the right to be able to go to school as a young lady and not think about, oh, I need to, trek up and down how many hours so I can't go today, or I'm on my period so I can't attend. I think that's kind of our overall message is that everyone has a voice and we're so much more powerful together, united. So we talked about so many different various stakeholders at different levels, but I think that both actually, all of us on the call have really emphasized that at the end of it, it's all about being our brother's keeper, patient community advocates. We have different terms and standards and our process and focus, but if we're not really interfacing directly with one another, then what are we doing? So I think what inspires Yuval is essentially the need and knowing that so much can be done with one another, coming together, even talks like this, um, or in the community. I think there was a question about that I saw or so in the chat of everyone plays a role, whether you're a researcher, a nurse, or someone within the community, in or outside of the healthcare. Outside of healthcare, I think that everyone has a voice. We should use it, and we can work together collectively to just better our lives and take care of one another.
Thank you, Faith. There was a question we had asked previously about leveraging technology and making sure we weren't furthering disparities in that whole role of access to technology. There are some questions in the chat box that I'll try to summarize that talks about data collection, data protection, role of private sectors in improving health outcomes. So, Dr. Etiebet, summarizing those questions, what is the role of the private sector in improving health outcomes? And then how do we leverage technology in an ethical way?
Yeah. No, thank you so much for the question. What I would say, and Faith, I loved what you just mentioned about we all have to be taking care of each other. We all are participating in society. These are our mothers, our sisters, aunts, daughters, friends, partners, who are affected by this, and nobody comes out unscathed. And so I think, again, when we talk about public sector and private sector, one of the things I like to say is that, for that pregnant person, they go between public and private sector, and they don't say, oh, I'm walking in through a private clinic right now, this is how I need to think about this. I'm walking into a public sector right now, this is how I think about this. They are going to where they think that they can get the best care, and they are able to access the best care. So they're moving between sectors. We also know that providers are moving between sectors. They're working in both sectors. Sometimes the conditions or other things may impact, the way that their care is given or even the results, but the same person is moving between sectors. What oftentimes is not moving, and this I think comes back to your previous question around efficiency, is data is not moving between sectors, and neither is the financing. So from a patient perspective, they should be able to get the highest quality, affordable care wherever, whenever, and however they want and need it. And sometimes it's only private sector that's available in their community. And we should be able to create a whole system approach, where we are bringing all of the capacity of the private sector, all of the capacity of the public sector, and all of the capacity of civil society together to be able to create an integrated journey and care continuum and care infrastructure for pregnant people. And so I think if we figure out how to do that, some of the resource some of the scarcity perspective around resources, we should be able to, I think, address some of that. We should also be able to address waste in the system, because we all know that sometimes when you move from one place to another, things are repeated or information is not shared. And so things fall through the cracks, which oftentimes leads to adverse outcomes. And so for the financing and the data to flow, unfortunately, that for the most part, if we don't want to put the burden on patients to carry their files with them wherever they're going, we need technology. And so it will be important, for us to think about interoperable technology, and technology that, as you said, protects the rights and privacy, of the patients, who are using it. I do think we're moving towards that, but it is uneven because there are just so many players, in the playing field, and it does require, I think, consensus around a shared vision and a North Star, and kind of redirection and incentivizing, towards that. But at the end of the day, and we know, speaking, as Nigerians, most of the care for maternal and reproductive health, especially in the south of Nigeria, is from local private providers, including informal private providers, where we actually have no idea about the quality of care that is being provided, and we need to do more to bring the informal into the formal system, to make sure that wherever women are going, they're getting high quality care.
Well, this is enlightening, and I'm just looking at all the different comments in the chat. Unfortunately, I wish we had extra time, but we'd have to wrap up. But last thing before we go is, we're halfway to the Sustainable Development Goals, and we all know we haven't necessarily made significant gains, especially in majority of the countries. So, Oni, what would be two things we would need to do to achieve the SDGs, or whatever version of measurement indicators we would want to use to measure health outcomes? And how does, I know you talked about what inspired your work, but maybe touch on that again and what you hope to see in the next 5 to 10 years.
Oh well, I'm like to achieve the SDGs. That's a good question. I mean, I think I like big goals. The SDGs are big goals, and I think I'll just say two things because I know we have to wrap up. I think the first one is something Faith and Dr. Tibet have said throughout. Is we have to stop pretending that health is independent of the rest of people's lives. Without water and sanitation, without gender equality, without access to infrastructure, we're not going to improve health. Like this is the system that we live in, and as providers, as researchers, for those who fund health for governments, there is no low hanging fruit you're going to pick up without these things. Like at the broad level, recognizing that women are important, that they are equal to men, will change how we prioritize their issues, and then working on that very high level social determinants, because very often we don't want to tackle the naughty problems because they're big. But if you unravel poverty, if we unravel data infrastructure, if you unravel corruption, then basically you've set us all up for success. And so I don't think it's going to be possible to achieve any of the health related MDGs, because maternal health is the bellwether of the health sector. It shows our failure as a society. It doesn't just show poor demand, poor supply. It shows our inability to work within a well-coordinated system. And then I think what you said for indicators, and I am doing like some work with my colleagues on this during the day, is we have to be willing to reinvent the wheel. We can't commit to the same old indicators and expect to see progress. Family planning as a field has made many more leaps, or let's even think of postpartum hemorrhage, because people were willing to do things that had not been done. They were willing to push the boundaries of the envelope. They were willing to think of how to measure things amongst marginalized people. I mean, it's not perfect, but moving to an indicator like intention to use, or willingness to use amongst women who want to use, is trying to capture women-centeredness, and we have to be bolder about it. We can't sit down on the hill of 8 antenatal visits and say that's sufficient. It doesn't move us forward. It doesn't tell us enough. And so being willing to step away from where we are comfortable as a global measurement community and to challenge ourselves to inch forward slowly. I don't think it will happen quickly, but to inch forward slowly in what we measure and what we value and how we include women's experiences, and trying to pull our data systems to catch up with those things, will get us closer to progress than I think we've made over the past few years. Yeah.
Thank you. And lastly, Dr. Etiebet, what inspires your work, and how do we get to the SDGs or whatever metric we're using to measure health, women's and maternal health outcomes?
Well, this inspires me and my work. So many people who are taking on this issue and taking it on from a variety of perspectives and keeping the pressure on. So thank you, including those who are listening. This has to be an all of society endeavor. It's not, we're not going to move the needle if we keep it in the health space, or even if we keep it in the kind of gender equity space. This is lives. This is our lives. This is our ability to live full lives. And so I am, I do think that there's more and more pressure to understand maternal mortality as a vital sign of society, and to use that, to also build momentum for these, major kind of structural issues and inequities, that we have to deal with. At the end of the day, if there is not respect for women, and respect for women's lives and valuing of women's lives, then we're not going to get where we need to get to. And I'm not sure how necessarily we move, that needle. But what I do say is that we can't let up the pressure, and all of us need to do our part to make sure that we are supporting young girls and women to find their voice, to shout their voice, and to support their voices.
Thank you all so much for a very enlightening conversation. To our audience, thank you for your patience. I know you all had great questions, and we hope we were able to address all of these. There was something you mentioned, Dr. Etiebet, about valuing women, and I think this is the perfect segue to just announce or at least highlight some of the work that our teams are doing, starting with the Value Her initiative from Yuval. Please go on the web page. There's the full length of the promo video we had shown earlier. Follow the work, contribute your own quota. Same thing with the MRHR Collective. We shared a snippet of the video earlier as well. Please follow that team. And for our speakers, they're on LinkedIn, they're on different platforms. I know you're really encouraged by all they shared today and their work. Please follow them on the different social media handles, get to follow their work, support the work. And, it takes all of us, and we all have to contribute our own quota. I know we're all here on a Saturday morning, 1.5 hours into the interview, we made it work. So thank you all for your patience. And we look forward to connecting with you all another time. Bye.
Thank you so much.